Serotonin norepinephrine reuptake inhibitors. Adding NET inhibition causes widening of the reach of these antidepressants to the monoamine neurotransmitter systems throughout more brain regions. Venlafaxine repeatedly seems to have greater antidepressant efficacy as the dose increases due to recruiting more and more NET inhibition. One area where SNRIs have established clear efficacy is the treatment of multiple pain syndromes, and also may have greater efficacy than SSRIs in treatment of vasomotor symptoms associated with premenopause, although this is not well established. As have previously been stated, NET inhibition increases DA in prefrontal cortex. Thus, commonly called dual action serotonin norepinephrine agents actually have a third action on dopamine in the prefrontal cortex. But they are not full triple action agents since they do not inhibit the DAT. SNRIs can perhaps be considered to have 2.5 actions. That is, they also boost dopamine specifically in prefrontal cortex, which is associated with several symptoms of depression. Although SERTs and NETs are abundant in the prefrontal cortex, the DATs are very few. That means that dopamine can diffuse away from the synapses and therefore can exert its action within a larger radius. But as studied in previous chapters, dopamine is also taken up by NET. In fact, NET has a greater affinity for DA than NE. NET blockade also lead to an increase in synaptic dopamine. Venlafaxine. Depending upon the dose, venlafaxine has different degree of inhibition of 5-HT reuptake, which is potent and robust even at low doses, versus norepinephrine reuptake, which is robust only at higher doses. It is controversial whether venlafaxine or other SNRIs has greater efficacy in major depression than SSRIs. But it seems plausible given the two mechanisms and the boosting of two monoamines. It is approved as well as widely used for several anxiety disorders as well. Adding NET inhibition likely accounts for two side effects of venlafaxine in some patients, that is sweating and elevated blood pressure. It is available as an extended release formulation for once daily administration. It also significantly reduces side effects, especially nausea. But even in controlled release formulation, it can cause withdrawal reactions, sometimes quite bothersome, especially after sudden discontinuation after high dose long-term treatments. It's converted to its active metabolite desvenlafaxine by PSY-PHI. Coming to desvenlafaxine, it has greater NET inhibition related to SERT inhibition as compared to its parent drug venlafaxine. The variability in plasma levels of venlafaxine versus desvenlafaxine is also due to genetic polymorphism of PSY-PHI, such that poor metabolizers will shift the ratio towards the parent, thus reduce the relative amount of NET inhibition. As a result, it can be somewhat unpredictable how much NET inhibition a given dose of venlafaxine will have in a given patient at a given time, whereas this is more predictable in desvenlafaxine. Studies have shown promising but inconsistent results for VMS in premenopausal women, with some SSRIs as well as with alpha-2 agonist clonidine and even with anticonvulsant agent gabapentin. Interestingly, the most promising result to date seemed to be with SNRI desvenlafaxine and may provide an alternative to ERT. However, it is not formally approved. The proposed mechanism of action being dysregulation of neurotransmitter systems within hypothalamic thermoregulatory centers by fluctuation of estrogen levels that lead to neurotransmitter deficiency that trigger both VMS and depression. And due to the loss of expression of sufficient number of brain glucose transporters due to low concentration of estrogen, many women continue to experience VMS postmenopausally. This in turn causes insufficient CNS transport of glucose, which would be detected by hypothalamic centers that would react by triggering a non-adrenergic alarm, with vasomotor response, increased blood flow to the brain, and compensatory increase in brain glucose transport. SNRI treatment could reduce this overactive hypothalamus. Observations suggest that SSRI seem to work better in women in the presence of estrogen. Thus, SSRI may have more reliable efficacy in premenopausal as well as postmenopausal women who are undergoing ERT. By contrast, SNRI seem to have a consistent efficacy in both pre- and postmenopausal women, whether they are undergoing ERT or not. Duloxetine. This SNRI has slightly more potent SERT than NET inhibition and has transformed how we think about depression and pain. Somatic pain was conceptualized classically as different from psychic pain and depression due to something wrong with the body and not due to something wrong with emotions. Somatic pain was thus not thought to be caused by depression, although depression could supposedly make it worse. Therefore, somatic pain was not treated with antidepressants. Studies with duloxetine has changed all this. Not only does this SNRI relieve depression in absence of pain, but it also relieves pain in the absence of depression. As we have studied, painful physical symptoms are frequently associated with major depressive episodes and are also one of the leading residual symptoms after treatment with antidepressants. All sorts of pain are improved by duloxetine, such as diabetic peripheral neuropathic pain, fibromyalgia, chronic musculoskeletal pain associated with osteoarthritis, as well as low back problems. Interestingly, the role of NET inhibition seems to be critical not only for the treatment of painful conditions with or without depression, but also in the treatment of cognitive symptoms in depression that are prominent in geriatric depression, a consequence of NET inhibition in prefrontal cortex. Duloxetine can be given once a day after the patient has had a chance to become tolerant, initiating at twice daily dosing. Another plus is that duloxetine may have lower incidence of hypertension and milder withdrawal reactions than venlafaxine. It is also an inhibitor of CYP2D6. Milnacipran. Interestingly, in US it is not approved for depression but is approved for fibromyalgia. It is a bit different from other SNRIs in that it is a relatively more potent NET than SERT inhibitor. And as previously noted, a robust NET inhibition suggests that it may be particularly useful in chronic pain-related conditions. It also has a favorable pharmacological profile for the treatment of cognitive symptoms, including cognitive symptoms of depression, as well as cognitive symptoms frequently associated with fibromyalgia, sometimes called fibrofog. It can be more energizing and activating than other SNRIs. Its enantiomer, levomilnacipran, is in clinical development as an antidepressant. But milnacipran may cause more sweating and urinary hesitancy because of its robust pro-noradrenergic actions at bladder alpha-1 receptors than some other SNRIs. An alpha-1 antagonist can reduce these symptoms. It is generally given twice daily because of its shorter half-life.